Good evening and welcome. I'm Kristi Epstein. I'm the nurse practitioner for the MS Clinic. I would like to welcome you to tonight's event. We thank you for joining us on our second virtual education series that we offer for people affected by MS. If you're here tonight, you are either living with MS yourself or you care about someone who's living with MS. Whatever your reason for joining us tonight, we are so glad that you're here. And we really hope that this series of webinars will be informative and helpful to you as you manage and flourish while living with this disease in your daily life. So let's go over a few housekeeping notes that you will need to know during this webinar. First of all, you are going to remain muted and your cameras will be turned off for the duration of the webinar. This session will be closed captioned and recorded for viewing at a later time. As you listen to the presentations, we want you to feel free to put your questions into the Q&A box. Just as a reminder, make sure that these are general questions and not containing any personalized information. These questions will be addressed at the end of the webinar by our Q&A panel. I am going to serve as the moderator for this evening's conversation. I am a nurse practitioner who specializes currently in multiple sclerosis. I have over 20 years of experience as a critical care nurse, and I have special certifications. I also have experience in infusion, oncology, and of course, neurology. My special interests within the MS clinic include wellness, reproductive issues, and of course, clinical research. With me tonight, we have the wonderful members of our MS team at The Ohio State University Wexner Medical Center. Dr. Benjamin Segal, Dr. Gyang, Dr. Robert Fallis, and Dr. Margaret Hansen. And we will be joined later during the Q&A session by our physical therapist, Grace Schaffner, and we're so happy to have her. We'll learn more about each of our presenters as we go through our event tonight. So let's start off with some poll questions. We're going to have interactive poll questions throughout the night, and we will put the questions up and we encourage you to answer by clicking submit. Let's read our first question. Vaccines are an important part of the health and well-being of our society and should be taken seriously. True or false? Please go ahead and submit your answers. We'll be able to see on your screen your answers. Give you a little bit of time to put those answers in. Let's take a look at your results. 100% of you agree. That is wonderful. So we all agree that vaccines should be taken seriously. So next, I'm going to move forward and I'm going to introduce our first speaker, Dr. Robert Fallis. Many of you know Dr. Robert Fallis. He's a neurologist and he specializes in taking care of patients with multiple sclerosis, demyelinating diseases of the central nervous system, as well as autoimmune diseases of the brain and spinal cord. Dr. Fallis has been involved with clinical research and MS drug trials for many, many years. When it comes to a care philosophy, Dr. Fallis takes time to create a treatment plan that is a perfect custom fit for each patient, and he finds it very rewarding to help educate his patients and give them a better quality of life. It is my distinct pleasure to introduce Dr. Robert Fallis. He is a member of the American Academy of Neurology in the MS section, and he has been named to the Castle-Conley list of regional top doctors every year to date since 2013. We're glad to welcome Dr. Fallis to talk about what you need to know about vaccines as a person with MS. Dr. Fallis, please, welcome.
Thank you, Kristi. That was very nice. And welcome everybody this evening. Glad to be here, and I'm glad everybody's taken time from their busy schedules to join us. So what I'm going to talk about is all about the basics of vaccines. If I can have the next slide, please. Next slide. So we're going to go through what is a vaccine, why are they important, what kinds of vaccines are there, and I know everybody has heard about population immunity. We'll talk about that, and vaccine safety. So this will be probably more than anybody wants to know about vaccines, but it'll be a general topic, and my colleagues will dive in and drill into it a bit deeper with specific topics later on. Give me the next slide, please. Next. So what is a vaccine? It's a biologic product that can safely lead to an immune response, and this immune response then protects you against subsequent infection or disease. And it basically allows your body to respond to a different virus or bacteria because the vaccine has led to the development of an immune response that can protect you. Can you go ahead and click again? Go ahead and click again. So vaccinations have reduced disability and death and reduced disease for many diseases. Click again. Click again, please. And they're safe and common. For example, many of us have had annual flu shots, and these have been extremely safe. Go ahead to the next slide. Next slide. So vaccination has had a tremendous impact on diseases, and these, on my computer, this graph is very difficult to see, but over in influenza here, and can't even read the name of this, influenza, diphtheria, all of these diseases, you can see the blue lines going to 0 following the initiation of a vaccine, which is in the box. And go ahead and click again. Click, please. And one of the greatest things in the scientific world of the last century was the global eradication of smallpox through vaccination, and it still remains eradicated. Please go to the next slide. One thing that I think is very surprising is that vaccination is nothing new. There's been a history of this for centuries, dating back before the 1500s in Europe, Africa, and Asia. It used to be called variolation, and this is a picture of Edward Jenner, who was an English physician scratching smallpox into a recipient child. Next slide. This was live virus vaccine. If you can give me the click again. In 2020, for instance, with COVID vaccine, everything is different, and genetic sequencing is used to identify a potential vaccine candidate with only a few days. So we've come a long way. Go ahead to the next slide. So click again. So we can see this on this timeline once she clicks the slide. Going from pre-1500s, it was introduced from Turkey to England by the English ambassador's wife in Turkey at this time in the 1700s. Louis Pasteur, who was a famous French biologist, was instrumental in developing it, a number of vaccines in the 1800s. And in the 1900s, of course, we have flu, then polio, and then 2020, COVID-19. Go ahead to the next slide. So what types of vaccines are there? So this will have direct impact on the subsequent speakers. They will go into this a bit more, but there's live attenuated vaccines. These live vaccines can replicate in the recipient. This will limit their use in people that are immunocompromised. And for instance, some live vaccines are varicella, the old shingles vaccine, not the new one, and the measles, mumps, rubella. And also there's a second type called non-live vaccines. These cannot replicate in the recipient. They propose absolutely no disease risk to an immunocompromised person. They are used with, usually combined with an adjuvant, which is simply a chemical that boosts the immune response. And as I said, live vaccines are not given to immunocompromised recipients. Next slide, please. Next slide. And this table gives a list of the live vaccinations, including yellow fever. But as you can see, most are not live vaccines. And if we go down to the bottom here, We can see COVID-19, which is a nucleic acid vaccine. There is no live virus. There is no dead virus. There is no virus at all in the COVID vaccines provided by Pfizer and Moderna. Johnson & Johnson is just moving forward to try to get one approved by the FDA, which is a dead virus. So there are other types. There's killed, there's toxoid like tetanus toxin, but these have all proven useful as viable vaccinations. Next slide. Go ahead and click. So what happens with the vaccination, and this is the crux of it, when a vaccine is given through the skin, it interacts with the immune system. And if you can click one more time, please, you'll see on the, after she clicks, there will be two circled cells here, B cells and T cells. Both of these cell types are very important in generating immune response in conjunction with other elements of the immune system. And as I'm sure other speakers will mention, B cells and T cells can be significantly affected by certain of the medications that we use to treat MS. And that if they are affected, then the vaccination effect can be blunted. What we're trying to do is get to the blue cells, which are plasma cells, which are actually little antibody factories that allow you to have protection against subsequent exposure. Next slide. Next one. Thanks. So what is population immunity? So vaccinations, of course, can provide individual protection, but vaccines also provide population protection. I really don't like the term herd immunity, so I'm going to generally call it population protection. Just as an aside, it's interesting that vaccination was first called variolation, which had to do with cows, and now we're talking about herd protection as well. So I'm going to talk about population protection. The vaccinations can reduce the spread of disease within a population. Next slide. Go ahead and click. Click. And if the blue is susceptible individuals, the kind of the coral colored is diseased. And one diseased person can affect the entire population. Go ahead and click. Click again. One more click. So if the population is vaccinated, but it's below the threshold for herd protection, the population will still generally be susceptible to the virus. If the vaccination coverage is above the threshold for herd protection, then everybody is protected. And this is what the infectious disease experts are looking for, is herd or population protection. Next slide. Go ahead and change it, please. And moving on to vaccine safety, all data existing at this point indicate the vaccines are in fact very safe. There are common side effects, including injection reaction, redness, swelling. You can have fever, headache, malaise. Serious side effects are extremely rare. For instance, anaphylaxis, which is an allergic reaction, will occur less than 1 in a million doses. People, of course, though, will learn about real or perceived vaccine safety issues through social media, which can affect people's ideas. Go ahead to the next slide. One more slide, please. So the challenges with vaccination is they only work if they are used. Of course, a vaccine that remains in the vial is about 0% effective, of course. The greatest challenge protection against serious infection disease remains vaccine access. And I don't know if we could even today we could have a more direct example of this, reading in the news how there are challenges distributing COVID vaccine. Communication is crucial to building confidence, explaining how vaccines work, which is the purpose of this webinar tonight, and explaining how vaccines are developed. So go ahead and give me the next slide, please. I think we're having a bit of delay on the slide movements. So decreasing vaccine coverage has led to outbreaks of infectious diseases, and there have been pockets of measles outbreaks. Of course, there may be philosophical or religious objections to vaccination. Survey data, however, suggests that a substantial proportion of adults may be unlikely to accept a COVID vaccine. Next slide. So in 2020, a multi-country survey of potential COVID vaccination acceptance across 19 countries indicated that 71% would be likely to take the vaccine. About 61% would get vaccinated if their employer recommended it. So let's look at the actual country by country results. If I could have the next slide. Thank you. So for a highly transmissible agent or a virus such as COVID or measles, 92 to 94% of the population must be vaccinated to prevent disease and to achieve a population immunity. In this bar graph, you see a number of countries who, including China, Brazil, a number of South American, Asian countries. The United States is, my screen is hard to read, so I'm not seeing it. It's here. The United States is here, all the way into the Asian countries, including Russia. So if you can click it once more, you can see after the animation advances that herd immunity threshold is actually about 92%, as I said. And across all countries, the acceptance of COVID-19 does not reach herd immunity threshold. This is worrisome for the countries that want to achieve herd immunity or population immunity. Can I have the last, next slide? I think this might be the last one. So in summary, vaccinations have been used for hundreds of years. Vaccines are very safe. They've reduced disease, disability, and death from a number of infectious diseases. Several types of vaccines are in use, and I prepared this slide before Johnson & Johnson, but the Pfizer and Moderna are the mRNA, the RNA nucleic acid vaccines. Vaccines will only work if they are used. So we're trying to educate and communicate about the need for this. I think that is the last slide. You can click through if you wish. I think there's just maybe some references on the last slide. No. So thank you very much.
Thank you so much, Dr. Fallis. What a wonderful presentation. That was really great information, and I'm sure that it has generated a lot of questions. So if you would all just utilize that Q&A box and put your questions in that we can address at the end of our Q&A session. So we are going to move on to our next talk, and it's going to be my pleasure to introduce our next speaker. Our next speaker is Dr. Gyang. Dr. Gyang is a neurologist specializing in treating multiple sclerosis, demyelinating diseases, and autoimmune disorders of the central nervous system. She is here with us at the Ohio State University College of Medicine, and she is the program director of our Multiple Sclerosis Fellowship. We're very happy to have her. She is currently the site principal investigator for MS clinical trials here at OSU, which is very exciting. She's collaborating with other disciplines to build a multidisciplinary clinic in neurorheumatology and neurosarcoidosis. She believes in providing customized, comprehensive, interdisciplinary care, giving patients the tools they need to thrive and maintain their quality of life. She is a National Multiple Sclerosis Society scholar and a member of the American Academy of Neurology. Dr. Gyang would like to start us thinking about MS drugs with a couple of quick poll questions. All right, so the questions will be on your screen for you to select your answer, and remember to click submit. Which of the following vaccine type is not recommended in individuals with MS? So please go ahead, choose your selection, and click submit. We'll give you a few minutes to get those answers in. Be interesting to see if we all agree. Remember to click submit. Okay, so about 88% of you said live attenuated vaccines are not recommended in individuals with MS. Excellent. All right, let's do one more. So which of the following is true on the effect of disease modifying therapies and vaccines? Read the answers carefully. And after you make your selection, make sure that you click submit. Give you a few seconds there to put your answers in. And then we'll take a look and see if we all agree. Okay, so about 69% of our audience agrees that some DMTs may reduce the effectiveness of vaccines. Nice job. So why don't you join me in welcoming Dr. Gyang to talk about DMTs and what their effects are on vaccines. Dr. Gyang, welcome, and we look forward to your talk.
Thank you very much, Kristi. I'm happy to present to you all today on the effects of disease-modifying therapies on vaccines. And that's going to follow Dr. Fallis's talk, which was really good. So we're going a little bit deeper into MS and disease-modifying therapies. Next slide, please. So as we saw in the polls, live attenuated vaccines are generally not recommended in patients with MS, especially patients that are immune suppressed. And what are some examples of live attenuated vaccines? So the measles, mumps, and rubella, varicella, which is chickenpox, shingles, and then the intranasal flu vaccine. That's not recommended in patients with MS, especially patients that are immune suppressed. But most other vaccine types are generally thought to be safe. So if we're thinking about the flu shot, the shingles vaccine has a variant, the Shingrix, that does not have a live particle in it, and that's thought to be relatively safe in patients with MS. We have, the tetanus vaccine, the pneumonia vaccine. Most of these are, in general, thought to be safe in patients with MS. And then some DMTs or some disease-modifying therapies can affect how we respond when we are given vaccinations. And I'm going to dive into the different DMTs and talk about what we know so far about how some DMTs affect vaccine response. Next slide. So the National MS Society just released guidelines about a week ago. And this is, word for word from the National MS Society, and that's why I have their logo up there. This is based on expert opinion. So there haven't been, we don't have any studies of the the COVID vaccine in MS patients. This is primarily based on expert opinion and the data we have so far. So the first point is that the Pfizer and the Moderna vaccine are safe for people with MS. And they can be used, in people that have MS that are on a disease-modifying therapy. And then the next point says that most DMTs are not expected to affect the response. So it says most, it didn't say all. And we will talk a little bit about the different DMTs and prior studies on other vaccines and what we've learned from them. They also recommend that in general, because the consequences of COVID are very serious and, some people can die, there's a recommendation to think about getting the vaccine. With some medications, there may be timing, in terms of timing the dose of the medication to your vaccination. But the general recommendation is that, we should all think about getting the vaccine to prevent COVID because the consequences of COVID can be very severe. Next slide, please. All right, so this table just gives us a view of all the disease-modifying therapies we have for MS, or all the categories of DMTs we have. So the first box, we look at beta interferons, and we have a variety of beta interferons. I'm sure a few of you would recognize some names there as drugs you're on. The next group is glatiramer acetate. So we have Copaxone and Glatopa. And then we have one of the pills, Aubagio or teriflunomide. We have the category of fumarates. So we have Tecfidera, Vumerity, and Berfatam. And then we have the Gilenya group, or the S1P1 inhibitors. So Gilenya, and two new drugs came out recently that are under that group, Mayzent and Zeposia. And then we have the B cell depleting therapies. Now, Dr. Fallis mentioned that vaccines, cause some new activity within B cells and T cells. So there are certain therapies that definitely select those B cells to deplete them. And we have 3 medications under that group: ocrelizumab, Kesimpta, and rituximab. And then we have Tysabri and adalimumab. And then there's a few others, Lemtrada or Mavenclad, that are all also used by patients with MS. Next slide, please. So I'm going to start talking about the different disease-modifying therapies and what we know so far based on studying these drugs when vaccines are given. So we start with interferon beta. There's been multiple studies that have looked at how patients on interferon beta respond to vaccines. So they've looked at the flu shot, the tetanus vaccine, and pneumonia vaccines. And the data tells us that these patients respond adequately, and they respond comparable to healthy controls, meaning that interferon beta does not significantly affect the response to a vaccine. And then secondly, we have the glatiramer acetate group. So we're talking about Copaxone and Glatopa. Similarly, there have been multiple studies, especially with the flu vaccine, that have shown that patients treated with Copaxone or glatiramer acetate have a very similar response to healthy controls. And so it doesn't really affect the response to vaccinations. One study showed that, maybe patients on Copaxone or patients on Copaxone did not respond as well as patients on beta interferons, but they had an adequate response to protect them from an infection. But that was just one study out of several studies that were done. Next slide, please. All right, so we're going to the oral medications now. So we have the group of fumarates. So with the fumarates, we have Tecfidera, and then newer drugs are Vumerity and Berfatam. So we have a few studies with Tecfidera. So the Tecfidera was looked at with the meningococcal vaccine, pneumonia vaccine, and the tetanus vaccine. And within these studies, patients treated with Tecfidera responded adequately, and they were very similar to patients on beta interferon. So what we believe is Tecfidera and probably drugs similar to Tecfidera are unlikely to affect how a patient responds to a vaccine when it's given. And then secondly, we have teriflunomide or Aubagio. Several studies as well. In most of these studies, these patients had a very adequate response. However, when these patients are compared to healthy controls, meaning patients not on Aubagio, the response was reduced. So they had a reduced response compared to healthy controls. However, that response was adequate, meaning it was enough to protect them from getting the infection. So Aubagio may have a mildly negative effect on the effectiveness of vaccines. Next slide, please. All right, so we go into the 2 groups that may be problematic. We have the S1P1 inhibitors, and the major medications in this group is Gilenya, and then we have 2 new drugs, Mayzent and Zeposia. So again, Gilenya is the one that has been studied more extensively since it's been out longer. And we looked at the tetanus vaccine, the influenza vaccine, and the H1N1. And in majority of these studies, there was a significantly reduced response to vaccination, meaning those antibody levels were much lower in patients treated with Gilenya in the study compared to healthy controls or patients that were not on, or healthy controls or patients that were on other medications, not Gilenya. So it's probable that the other 2 drugs, Mayzent and Zeposia, may act the same way. And then secondly, we have the B cell depleting therapies. So we have ocrelizumab, rituximab, and Kesimpta. So both ocrelizumab and rituximab, they've extensively been studied, And as we all know, ocrelizumab, and they all suppress B cells. And we know that those B cells are very important to the production of antibodies, because the B cells evolve into plasma cells, and those plasma cells produce antibodies. So studies have shown that there's a significant reduction in response to vaccines in patients treated with these drugs. And this is the group that I think is the most concerning in patients getting vaccinations. And the main recommendation that we have is, discussing timing, because a few of these medications are given, within long intervals, and they deplete the B cells for several months, once a dose is given. So these are the two main categories that may be problematic when it comes to vaccine response. Next slide, please. Okay, so we have a few other categories. Tysabri or natalizumab. That has also been studied, and we looked at the influenza vaccine in patients on Tysabri versus healthy controls, and there was no reduction in response to that vaccine. So basically, Tysabri treated patients were similar to healthy controls, and therefore, if you're on Tysabri, it's unlikely that that's going to affect the response to vaccination. Cladribine or Mavenclad, we don't really have any studies in MS, so there's not a lot of data about how the medication will affect the response to vaccines. Thankfully, it's not a medication that's dosed very regularly, and so if you are planning on starting a medication like that, you definitely need to talk to your doctor about when to start it relative to getting your COVID vaccine. And then finally, we have Lemtrada or alemtuzumab. Now, in a study that looked at patients treated with Lemtrada, most of them responded to vaccines, but within the first 6 months of getting Lemtrada, there was a reduced response. A lower number of people responded adequately. So, this tells us that within the first 6 months of treatment with Lemtrada, response to vaccinations may not be appropriate, or may not be as high as we want it to be. And there may be some benefit in delaying a treatment, or, holding off on the vaccine until after that 6-month mark. Of course, we say with all questions, you want to talk to your neurologist and have a conversation, depending on what medication you're on when is the optimal time for you to get the COVID vaccine or any other vaccinations you may be thinking about. Next slide, please. Okay, so in summary, we went over a variety of disease-modifying therapies, and we talked about some of them, especially the B-cell depleting therapies and the Gilenya group. Those two groups were noted as the two that may affect the response to vaccinations. And so most of the others do not significantly affect how we respond to vaccines, at least from trials we've seen with other drugs. And the big, take-home point is you want to have a discussion with your doctor. If you're on any of these treatments that may potentially affect how you respond to vaccinations, have a discussion with your neurologist to come up with what's the best time to get the vaccine, and should there be a delay in the treatment, or should there be a delay in the vaccination? We also talked about Lemtrada or alemtuzumab, where we said the first 6 months after the treatment, there may be a reduced response to vaccines. And so if there's a treatment that's coming up, you want to be able to time that appropriately so that you're not caught in that 6-month window. Next slide, please. So I think that's the end of my presentation, but Dr. Segal is going to talk about this. We have a study that's going to look at how patients with MS respond to the COVID vaccine. So if you have MS or NMO, which is neuromyelitis optica, or MOG antibody-related syndrome, you may qualify for this study, and there's a contact number or email on the screen, and reach out to us because we have started enrollment already. And basically we're getting antibody levels before you get the COVID vaccine and after you get the COVID vaccine, to determine how well patients with MS on different disease modifying drugs respond to the COVID vaccine. So thank you very much for the opportunity to talk to you, and I'm going to hand it over to Kristi.
Thank you so much, Dr. Gyang. What a wonderful, wonderful talk. And there was a lot of really great specific information in there. And I love how this is all building. Talks are building upon one another. And so I want all of you out there to go ahead and put your questions in. Remember, we're going to address your questions in Q&A. And we're going to talk a little bit more about that COVID study, which is very important and is going to provide some really excellent information for the MS community around the world. So next, it is going to be my distinct pleasure to welcome Dr. Margaret Hansen. Many of you know her. She is our clinical pharmacist on the MS team, and she did join our team in August of 2019, and we are so happy to have her. She received her PharmD from the University of Kansas, and then she completed 2 years of postgraduate residency training. And Dr. Hansen loves to meet with patients who are newly diagnosed with multiple sclerosis and are planning or maybe planning to switch their disease modifying therapy to a different medication. She specializes in going over baseline information, screening, and providing education about MS medicines. She also provides long-term lab safety monitoring for all of these medications. So just in case your primary provider forgets anything, Margaret is there to make sure that nothing gets left out. She shares that she especially loves her job because she gets to help people better understand their disease and their medicine. So before we join Dr. Hansen, let's do another quick poll question. So let me ask you guys, how are you feeling about getting the COVID-19 vaccine? I want you to be honest, really answer from your heart, and remember, go ahead and click submit when you're ready to put your answer in. We're going to give you a few minutes to put that in. Be honest, really think about it. And we'll give you a few minutes and we'll see what your response is. I want to let you know that we've probably all had the same feelings, and most of us on your medical care team have probably already received the vaccine. So we can relate to what you're going through and considering what you should do and what is best for you. Okay, so excellent. It looks like 63% of people who are responding are ready. They say, I'm ready and give it to me. That's good to know. And I hope that some of the information tonight is helping kind of alleviate some of those fears. And remember, if you have questions, please put them in the Q&A. So now it is my distinct pleasure to go ahead and introduce Dr. Hansen. Margaret?
Thank you, Kristi. I'm very excited to be here, and I'm very excited for everyone who has tuned in today for this very important topic. So I'm going to be covering the COVID-19 vaccine and how this applies to our MS population. Next, please. Okay, so a little bit of a disclaimer. As we're all used to this year, the COVID-19 pandemic is rapidly changing all the time, and there are changes in public health recommendations that go along with these changes. So every effort has been made to give the most up-to-date and accurate information, but it will be important to continue to seek additional information as the pandemic and the COVID vaccine rollout continues. So please seek reputable resources like the CDC website or talk to your healthcare providers for ongoing recommendations. Next. So unfortunately, we are all too familiar with what the coronavirus disease or COVID-19 respiratory disease caused by the SARS-CoV-2 virus is. We've been dealing with this for about over a year now, and I think many of us did not expect to still be talking about coronavirus over a year later. However, we can see that we're still in the heart of this pandemic, with over 27 million Americans having been infected with the coronavirus and over 460,000 Americans losing their lives. We need a way to prevent the spread of this disease and its deadly effects. Next. So, vaccines to prevent coronavirus disease are likely going to play a very crucial role in ending this pandemic. In December of 2020, the FDA issued emergency use authorizations allowing the use of the first 2 COVID-19 vaccines in the United States. Both the Pfizer-BioNTech and Moderna vaccines are non-live messenger RNA vaccines. These vaccines work by delivering the instructions for your body to make the spike protein that is found on the surface of the coronavirus. Your cells use these instructions to make the spike protein, which is harmless to you because it is a very small piece of the coronavirus. Your immune system then detects that the spike protein is foreign and it makes antibodies to it. I like to think of antibodies as kind of the magic bullets of the immune system that specifically recognize foreign invaders like viruses and tag them to be destroyed by the immune system and eliminate them quickly before they can make you sick. The COVID-19 vaccine can in no way give you the coronavirus, nor can the mRNA in the vaccine have any effect on your own DNA. The messenger RNA is quickly broken down by the body after you've made the spike protein. Next. As part of the FDA emergency use authorization, both mRNA COVID-19 vaccines underwent the standard required clinical trials that all new medications and vaccines must undergo. Safety and effectiveness were established through 2 large clinical studies. The Pfizer study enrolled over 43,000 people aged 16 and older, and the Moderna study enrolled over 30,000 people age 18 and older. In both studies, half of the people received the vaccine and the other half received a placebo, which contained no active drug. People were excluded from the studies if they had a previous confirmed case of COVID-19, or if they were taking immunosuppressing medication or had an immunocompromising condition. Pregnant and breastfeeding women were also excluded. While people with MS and other autoimmune disorders were not specifically excluded from the clinical trials, we don't know how many people were included. MS, the disease, is not an immunocompromising condition in itself, but the medications that we use to treat MS do affect the immune system, and is not known which MS medications may have caused a person to be excluded from the studies. The studies were designed to measure the safety and the effectiveness of 2 doses of mRNA COVID-19 vaccine in preventing confirmed coronavirus disease. Next. Looking first at the effectiveness of the Pfizer vaccine, there were a total of 170 cases of confirmed COVID-19 that occurred at least 7 days after the 2 doses of the vaccine or 2 doses of placebo were administered. 162 of the 170 of those cases occurred in people who received a placebo, compared to only 8 people who had received the Pfizer COVID-19 vaccine. This translates to a 95% effectiveness in preventing coronavirus disease for those who received the vaccine compared to no vaccine or placebo. During the 3 weeks between dose 1 and dose 2 of the Pfizer vaccine, there were 82 COVID-19 cases in the placebo group, compared to 39 in the group that received the vaccine. And this is reported as a 52% effectiveness after 1 dose. However, it may be reasonable to expect that the effectiveness of the vaccine may be higher after that first dose, as most of those cases were clustered in the first 12 days after the first dose. And it does take the immune system 1 to 2 weeks to really respond to the vaccine. But nevertheless, this finding supports that both the Pfizer and the Moderna vaccines were studied as 2 doses and need to be given as 2 doses to get your maximum effectiveness from it. Next, please. Next, looking at the results from the Moderna study, there were 196 cases of confirmed COVID-19 that occurred at least 7 days after the 2 doses. 185 of those cases were in people who received the placebo, and only 11 cases were in those who received the vaccine. Again, this translates into a similar result as the Pfizer study with 94% effectiveness. Additionally, of the 30 severe COVID-19 infections that occurred in the study, there were no severe cases that occurred in the group that received the vaccine, which gives some support that even if somebody gets sick with COVID-19 and has received the vaccine, they may have a less severe case. Next, please. Overall, these vaccines were generally well tolerated, and the same side effects were reported at similar rates between the 2 studies. Arm soreness and pain at the site of the shot was the most common side effect, followed by feeling tired, having a headache, muscle aches, and chills. Most were mild to moderate and lasted 1 to 2 days after the shot. Side effects were reported more frequently after the second dose and may be more common and may be more intense in those under the age of 55. There were no reports of severe allergic reactions, including anaphylaxis, in the clinical trials. However, severe allergic reactions are a known but rare possible side effect for any vaccine. Early safety monitoring for both the Pfizer and the Moderna vaccines was conducted soon after they began using it in the wider population. And they found 21 cases of anaphylaxis or severe allergic reaction out of the 1.8 million doses of Pfizer vaccine that had been administered, and 10 cases in over 4 million doses of Moderna vaccine that had been administered. All patients did recover, and there were no deaths reported from the anaphylaxis. About 80 to 90% of the people who had a severe allergic reaction had previously reported severe allergic reactions to something else, whether a medication, a food, a vaccine. About half of them had previously had anaphylactic reactions. Typically, the onset of anaphylactic reactions are within the first 30 minutes after a dose. While anaphylaxis is scary and potentially life-threatening allergic reaction, it is a known and a rare risk for any vaccine. It is especially important to tell your vaccinator and your healthcare providers about any types of severe allergic reactions you may have had in the past, especially if they occurred within an hour of being exposed. And it is also important to balance the risks associated with the vaccine with the risks of a COVID-19 infection. So based upon the results of the large clinical trials that showed these vaccines were both highly effective and safe, the Pfizer and Moderna mRNA COVID-19 vaccines were granted emergency use authorization by the FDA to begin vaccinating people against the corona-19 virus. Next. So who should not receive the COVID-19 vaccine? The only people who we know should not receive the COVID-19 vaccine for sure are those with a known severe or immediate allergic reaction to an mRNA COVID-19 vaccine, a component of the vaccine, or to polyethylene glycol or PEG or polysorbate. Polyethylene glycol is a component in both of the mRNA COVID-19 vaccines, and people who are allergic to polysorbate may also have a reaction to PEG. However, we saw that there were certain groups who were excluded from the clinical trials, and we do not know how many people with autoimmune conditions including MS, were included. However, there is not a recommendation for these patients to avoid the COVID-19 vaccine. Some groups may need to take precautions before receiving the mRNA COVID-19 vaccine, especially if you have had a previous severe allergic reaction. You should talk to your healthcare provider and the person providing your vaccine to see if you may be someone who should receive pre-medication to help reduce the risk of having a severe allergic reaction. Those with bleeding disorders should talk to their hematologist to make sure it's safe for them to get an injection into muscle. And those taking a blood thinner can still receive the vaccine, but sometimes we put a little extra pressure on the site for about 5 minutes just to prevent some extra bleeding. Next, please. So the big question, right? Should a person with MS get an mRNA COVID-19 vaccine? While we have limited information specifically for the use of this vaccine in an MS population, we do have expert groups convening from the American Academy of Neurology and the National MS Society who have issued guidance supporting vaccination with mRNA COVID-19 vaccines for people with neurologic conditions, including multiple sclerosis. And this support is based upon long-term evidence that we've seen from our previous presenters from Dr. Fallis and Dr. Gyang, that immunizations are safe, effective, and widely recommended for people with multiple sclerosis. And there is no reason to expect that the COVID-19 vaccine would be different. And at this time, we have over 46 million doses of both the Pfizer and the Moderna vaccines having already been administered to Americans. And we have not seen any safety reports at this time that cause us additional concern for our MS patients. While there may be some timing considerations based upon the MS medication that you're on that you should discuss with your neurologist, overall, the MS team at OSU believes in the importance of being vaccinated against the COVID-19 virus as a way to prevent serious disease and hopefully put us back on a track to normalcy. At this time, these recommendations, I do want to kind of point out a caveat, do apply to the Pfizer and the Moderna mRNA COVID vaccines. As more COVID vaccines are approved, it is important to talk with your provider that all manufacturers remain equally preferred or recommended, and all vaccine types remain preferred and equally recommended. So next, I do want to cover some practical resources, I hope, for kind of tracking when a person may become eligible to receive the vaccine and where they can get it. Next. So right now, it may feel very difficult to know when a person might be able to get the COVID-19 vaccine. Due to limited supplies, it's being rolled out in a phased approach. And we are currently in phase 1, which is due to a limited supply of vaccine. In the state of Ohio, as of this week, this now includes adults 65 and older, healthcare workers, school employees, people living in facilities, and certain disease states. MS does not make someone eligible for a phase 1 distribution at this time. As this information changes and more people are eligible to receive the vaccine, your state Department of Health website is likely the best source of this information to track when you might be eligible to receive it. Next. So where can you get the COVID-19 vaccine? At OSU, we're administering the vaccine 6 days a week at the Schottenstein Center. I'm there 2 days a week myself. Anybody who's an OSU patient and has an active MyChart account will receive a MyChart message when they're eligible to schedule for the vaccine. People who do not see a provider at OSU can also still sign up for a MyChart account and receive that notification and schedule through MyChart. The phone number provided there under OSU is also available for scheduling appointments. The OSU website also has great information about the vaccine, links to the Ohio Department of Health and ways to learn about what we're doing at OSU with the COVID vaccine. The Ohio Department of Health is another great resource, and the website is listed there. On that website, you can find all of the locations where the COVID vaccine is being given. You can sort it by county, I do believe, and by town alphabetically. They also have a 7-day-a-week kind of help phone number that you can call with questions about where you can get the vaccine and other questions that come up. For those tuning in outside of Ohio, likely your state Department of Health website is going to be your best resource. These tends to be the agency that's controlling your state's COVID-19 vaccination program. However, the CDC also has a really handy tool at that website listed where you can put in your state or territory and it automatically links you to your state's page for the COVID-19 vaccine program. Next, please. So once you are eligible and you're able to receive the mRNA COVID-19 vaccine, things to know about the vaccine are, there are currently no preference or recommendation to get one manufacturer over the other. They are generally the same effectiveness. They typically have the same types of side effects. And at this point, our supply is limited and you should get the vaccine that is available to you. It is important that whatever your first dose is, you need to get the same manufacturer for the second dose. Pfizer is given in 2 doses separated by 21 days. Moderna is given as 2 doses separated by 28 days. It's important to know, since we've been telling you now for 3 presentations to get immunizations, you should not get another immunization within 14 days of the COVID-19 vaccine. So I've been telling the people I've been seeing, if I'm recommending a non-COVID-19 vaccine to you and you get the opportunity to get the COVID-19 vaccine, put those other vaccines on hold until you complete your COVID-19 series. And then at least 2 weeks later, you can resume getting other vaccines. You will receive a CDC vaccination card as your proof of your vaccination. Keep that, take a picture of it. It could be very important for proving your vaccination status. You will be observed for 15 to 30 minutes after the shot. If you've had previous allergic reactions, likely you will be there for 30 minutes. This is for your safety, so please just be very frank with your vaccinator of any previous reactions. Last point, side effects are normal. The COVID vaccine can cause some side effects, the arm soreness, some of those flu-like symptoms, but it is a sign your immune system is responding, and they are typically short-lived. You can try cold compresses on your arm. Using your arm throughout the day can get blood flow there and help decrease some of that pain. Being well hydrated and using Tylenol or Advil for any symptoms is okay. Full effectiveness is not expected for at least 2 weeks after the second dose. Next, please. Despite our clinical trials and administering this, there are still lots of questions to be answered. Some of the big ones are, how long does immunity from the mRNA COVID-19 vaccine last? We don't know this at this time. We don't know if a booster will be required because of decreasing immunity or maybe because of new variants, if boosters will be required. Can a vaccinated person continue to spread the COVID-19 virus? Our hope is that this vaccination prevents that spread, but for those asymptomatic people who might get exposed, we don't know that they couldn't still spread. So it is very, very important to still continue our containment measures, wearing masks, staying socially distanced, washing hands, avoiding crowds for the time being. Next, please. Final points I want to make. The mRNA COVID-19 vaccines have been shown to be safe and effective through 2 large clinical trials. Patients with MS are encouraged to get the COVID-19 vaccine when it becomes available to you. Side effects are generally mild or moderate and are signs that your immune system is responding to the vaccine. You should speak with your neurologist and other healthcare providers if you have any additional questions or concerns about the COVID-19 vaccine. And finally, one of the most important points is to continue to protect yourself and others. Vaccine is another step on the path to normalcy, but we still have to maintain our discipline, our sacrifice to keep beating this vaccine down. Thank you. Next.
Thank you, Margaret. What a wonderful and very, very complete talk. And I'm sure that actually probably answered a lot of questions that our patients have. So thank you. And again, I would encourage you all, if you have questions, please enter them into the Q&A portion and hit submit. And it's going to be my pleasure to introduce our last speaker. Our final speaker of the evening is Dr. Benjamin Segal. He is the chairman of our Department of Neurology and the director of the Multiple Sclerosis Center here at the Ohio State University Wexner Medical Center. Dr. Segal, as you know, is an internationally respected thought leader in the MS community. He has published over 100 original research articles in high impact journals, and his research is supported by annual funding from the NIH, the National Institute of Health, in excess of $1.3 million. Dr. Segal has been on the Best Doctors in America list each year since 2010, and he has received multiple research awards, including the Harry Weaver Neuroscience Scholar Award from the National MS Society. Dr. Segal is also the director of the America's Committee for Teaching and Research in MS, APRN-CNP. And that is the largest academic organization in North America. This past fall, he organized the MS Virtual 2020, a global conference on cutting edge research in MS that was attended by 10,000 MS physicians, scientists, and trainees. I attended and it was wonderful. Thank you, Dr. Segal. Dr. Segal tonight will be discussing MS research studies, and he will do a final poll question in order to get ready for the presentation. So I'm going to go ahead and start with the poll question prior to Dr. Segal's presentation. What are the most pressing topics in MS research? So take a look at those answers there and let us know what you think. Be interesting to see what everyone thinks about what might be going on in MS research right now. Make sure that you put in your response and hit submit. Give you a few minutes and we'll take a look at what your responses are. And get those responses in so we can take a look real quick and get to Dr. Segal. Okay, so 77% of you feel that new treatments that promote repair of the damaged nervous system. And interestingly, Dr. Segal's team has recently been in the news for some really great research in that area. So without further delay, it is my pleasure to introduce Dr. Benjamin Segal. Dr. Segal?
Thank you, Kristi. It's a pleasure to speak to you all, and I enjoyed hearing my colleagues' talks as well. So there's no right answer to that poll question. It's interesting that there was a interest in all of those possibilities, but I'm going to touch on research that addresses each one of those topics. So as many of you know, multiple sclerosis is quite diverse and it's unique from one patient to another. And I guess we skipped ahead a couple of slides, but right now this cartoon shows the natural history of multiple sclerosis, and the bumps on that curve indicate relapses in a patient with relapsing remitting disease. And then that upward trajectory that's a little bit further to the right indicates progressive disease. And the reason I'm showing you this is that there are certain treatments that are more appropriate for relapsing remitting MS than progressive MS. Some drugs that we use in relapsing remitting disease are not quite as effective when someone begins to accumulate disability slowly. So we have a lot of goals in research in the MS world today. We do have over 15 drugs that decrease the risk of relapses. However, we don't have a cure, and not everyone responds to a particular drug. So we always want to find new drugs for relapsing or remitting MS that increase our options. Also, some people have side effects to currently used drugs, further indicating that we have to find safer and more effective treatments. But perhaps more pressing is the need for drugs in patients with progressive MS. Some of the drugs that we use in relapsing remitting disease do tend to slow progression, but those drugs tend to work best in progressive patients who are younger and or who have superimposed new lesions or relapses. So we want to find drugs that treat patients who have progressive disease as they age and even in the absence of any inflammatory activity or relapses. Next slide, please. However, none of the drugs that we have currently available actually reverse damage. So one of our biggest priorities in research today are to discover treatments that actually lead to repair. We also, as I just said, want to discover safer, more effective drugs for relapsing MS and treatments that are better at slowing or halting MS progression. Also, when we're managing patients, it would be very useful if we had new tests that would allow us to diagnose progressive MS earlier. And that goes back to the concept I mentioned earlier that some drugs that we use for relapsing remitting MS are no longer effective in progressive MS. So the sooner we know someone is going into progressive disease, we may want to discontinue a therapy and or possibly start a different drug. And a very timely topic during the pandemic is whether the COVID vaccine is going to be as effective in people with MS as a general population, and whether MS drugs are going to blunt the immune response to the vaccine. Next slide, please. So the first question, how can we reverse neurological damage in MS and other diseases? Well, we are very ardent here at OSU to try to discover drugs that actually stimulate regeneration of damaged nerve fibers and that induce remyelination. Next slide, please. So our labs at OSU recently published a paper that looks into actually skewing the immune system or the immune response in a way that converts the destructive immune response in diseases like MS to actually a protective immune response. Next slide, please. And we've actually discovered a new immune cell that stimulates nerve fiber regeneration. So this cell, if we inject it near sick nerves, including nerves that have transected or broken nerve fibers, these new immune cells actually release growth factors that increase the survival of the sick nerve cells, but also stimulate them to grow new nerve fibers. Now, the initial studies were done in mouse models of trauma to the nervous system, spinal cord trauma and optic nerve trauma. But these cells could potentially also be beneficial in MS because there's nerve fiber damage very frequently in MS lesions. So right now, scientists at OSU are exploring whether this new type of immune cell can be beneficial in animal models of MS. And we're also trying to identify the human counterpart of this mouse pro-regenerative protective immune cell. Next slide, please. So there are a lot of other research questions that we are that we are trying to answer. And one of those is, are there new alternative drugs that decrease the risk of relapses in people with relapsing MS? And what about drugs that slow progressive clinical decline in people with MS? So next slide. So our team, headed by Dr. Gyang, is about to embark on new clinical trials that are testing a new type of disease-modifying therapy, both in relapsing MS and in progressive MS. So this drug is a drug that actually inhibits an enzyme called Bruton's tyrosine kinase. So this enzyme is present in destructive immune cells, the types of immune cells that cause damage to myelin and nerve fibers in multiple sclerosis, including immune cells called B cells and also immune cells called myeloid cells, which include monocytes, which circulate in the blood, but there's also a type of myeloid cell normally present in the brain and spinal cord and optic nerves called microglia. And these microglia get activated and angry during multiple sclerosis and cause damage, in addition to the blood-borne immune cells that infiltrate the nervous system and cause damage. So the interesting thing about this new type of drug, it blocks this enzyme that's necessary for the activation and function of both B cells and myeloid cells, including the microglia I just mentioned that are normally present in the nervous system. There's a variant of this drug called ibrutinib that's currently used in graft versus host disease, which is occurs in transplant patients. And like MS, it is driven by destructive inflammation that causes damage to different tissues. So this drug is now being considered for both relapsing, remitting, and progressive MS. Next slide, please. There has already been an early trial of a Bruton tyrosine kinase inhibitor in relapsing MS. So that's the class of drug that we're going to be testing here. And in that trial, this was of patients with both relapsing remitting MS and patients with secondary progressive MS who had superimposed relapses. Most of the people in the trial were women, all were white. And the drug was tested against placebo as well as against another approved MS drug, dimethyl fumarate, or also known as Tecfidera. And what they found was that at one of the higher doses of this new drug, that there was a significant decrease in the number of new inflammatory lesions visualized on MRI scan. Now, there were some side effects. There were modest increases in liver enzymes. We also see that in many of the drugs we use now. And there was also some cases of nasopharyngitis. Next slide, please. So in addition to the trial I just mentioned, another member of this class of drugs has been tried in relapsing MS. And in this case, the drug was compared at different doses against placebo. And at the higher dose of the drug, there was an 85% relative reduction in new inflammatory lesions detected on MRI scan, as well as an 89% relative reduction in new or enlarging lesions, white MS lesions. So this particular agent is now being tested in larger trials of both relapsing and progressive MS. Next slide, please. Now we're interested in this drug, particularly in progressive MS, because we know that it could turn off these microglia, these immune cells that are already in the nervous system, and those microglia, once they get activated and angry, have been implicated in causing the damage of progressive MS. Next slide, please. So there are a number of trials of this class of drug now ongoing in multiple sclerosis, and the two that are highlighted in red in the middle of the chart, we are participating in. So there is going to be a trial in relapsing MS as well as primary progressive MS. The trial in relapsing MS, subjects will either get the new drug, they'll get placebo, or they'll get teriflunomide, which is also called Aubagio. For the trial in progressive MS, the subjects will either get the new drug or placebo. Next slide, please. This new drug, we always are concerned about the effects of drugs during the pandemic on the COVID-19 infection. There's not a lot of data on the effects of this new drug on COVID-19, but there are 2 small reports. In one report, it seemed that the patients who were on COVID-19 were actually less likely to get severe complications of the infection. Once again, this only involved 6 patients, and these were patients who were being treated with the drug for a type of cancer. In contrast, in another study of, once again, of only 2 patients, it appeared that these individuals contracted COVID-19 while on the drug, developed some breathing problems, both discontinued the drug and fully recovered. Next slide, please. So another research question that we're trying to answer here at OSU is, can we improve doctors' abilities to make a diagnosis of progressive MS more accurately and sooner during the disease course? And next slide, please. Here are the results of a study where we are measuring particular factors in the blood that are involved in destructive inflammation, particular for progressive MS. And if you look on at the figures in the center of the graph, the blue line indicates levels of certain factors in progressive MS, and the red in relapsing remitting. So we're beginning to identify factors that we can measure in the blood that may allow us to distinguish progressive MS from relapsing or remitting MS, which becomes an important issue when someone is transitioning. It seems to be getting a bit worse, and we're not sure if they're entering the progressive phase yet. This could help us get a better idea in terms of how their disease is evolving. Next slide, please. So an important question, and many of you touched on this in the Q&A, is how do people with MS respond to the COVID-19 vaccine compared to the general population? And do MS drugs reduce the effectiveness of the COVID-19 vaccine? Next slide, please. So this is an important question. There is some information about the effects of currently used disease-modifying therapies on the effectiveness of standard vaccines like the flu vaccine. So several studies indicate that the immune response to many different vaccines are preserved in people with MS who are treated with beta interferons. There's also some data suggesting that vaccine responses are also preserved in patients treated with Tecfidera or dimethyl fumarate. Now, in a number of other studies, vaccine responses were found to be reduced to varying degrees in patients treated with Copaxone or glutamate acetate, teriflunomide or Aubagio, sphingosine 1-phosphate receptor modulators, that includes Gilenya and Mayzent, and natalizumab, which is another name for Tysabri. So people were able to mount immune responses to these vaccines, but they weren't quite as robust in individuals who are not on those drugs. And everyone's different, so some people had better responses than others. But in general, some of the drugs that I just mentioned blunted the response to the vaccines. The drugs that have been shown to have the most profound effect on vaccine efficacy are the B-cell depleting antibodies. So that includes rituximab and ocrelizumab. So these drugs do appear to have the most negative impact on vaccines. The new drug Kesimpta, we predict would also really blunt responses to vaccines. Now, what I just mentioned refers to the vaccines that are currently in use. Those vaccines tend to be composed of proteins or fragments of proteins or killed viruses, and they're essentially quite different from the COVID-19 vaccines, which are composed of genetic materials. So we really don't know the impact of any of these disease-modifying therapies on the new COVID-19 vaccines as of yet. Next slide, please. So we are about to start a study that addresses the question of how will our patients with MS respond to the COVID-19 vaccines, whether or not they're on disease-modifying therapies. And so in this study, we will obtain blood before someone gets the vaccine, as well as after they get the vaccine. And if subjects who are enrolled in the study are willing, we may retest them several times and compare them against people with MS who are on drugs or are not on drugs, as well as people without MS. And this will let us know how effective the vaccines are if patients are mounting a protective immune response. Another thing I wanted to mention is that we are measuring the immune response with a very special test that specifically is indicative of protective immunity. And this unique test was actually developed by scientists at OSU. So thank you for your attention. That's just a summary of some of the research going on here. We are expanding our research portfolio. We actually have more MS doctors and scientists who are going to be joining us over the course of the next year. And we plan to keep deepening and diversifying the different types of research projects we're doing to increase our understanding of MS and to find better ways to treat it. Thank you for your attention.
Thank you so much, Dr. Segal. What an exciting and hopeful talk. And it's always really wonderful for us to hear about exciting things that are happening in the research environment. And we're so lucky to have you here to elevate the level of research here at Ohio State University. So with that being said, I think it's time for us to move on to our question and answer panel. And I'm going to welcome the entire group for question and answer. And I would like to also welcome Dr. Grace Schaffner. She is our outpatient coordinator, the outpatient rehab multiple sclerosis program coordinator, let me say. And she has a very special interest in multiple sclerosis, vestibular conditions, and community fitness. So she's going to join the full panel, and we're going to be looking at the questions that you've submitted over the last hour. So we're going to try to get to as many questions as we possibly can. And remember that all of your questions will be recorded, and if not answered during our Q&A, they will be addressed after the fact. All your answers will be recorded and they will be uploaded. So during this time, Dr. Segal is going to take over and he's going to read the questions, and all of our panelists will chime in and answer. So let's have some questions.
Thank you, Kristi. There's a question that I'd like to answer very briefly. The question is, what does it mean to have the vaccine response preserved? What I meant by that is to have a normal response to the vaccine, in that most people will mount an immune response. Usually that's in the form of antibodies that protect you against the actual infection that you're being vaccinated against. So to say that the vaccine response is preserved, it means that you are able to mount a protective immune response despite being on a particular therapy or despite having a particular condition. So there have been a number of questions about the safety of the COVID-19 vaccine. And in particular, one of the questioners mentioned that there was a report that was published about a case of transverse myelitis in one of the subjects who received the AstraZeneca vaccine during a clinical trial. So the AstraZeneca vaccine is not one of the vaccines that is currently being administered in this country, but there was that one case. And so that raises concern, since transverse myelitis can occur during MS. Could COVID-19, the COVID-19 vaccine, trigger a relapse or transverse myelitis, or worsen the MS clinical course? So I'm going to address that first question to Dr. Gyang, and then see if any of the other speakers have comments.
Is this a question on the AstraZeneca vaccine?
Well, I would ask you to address all of the vaccines.
Oh, all of the vaccines. Okay. So basically, we have the 2 mRNA vaccines that are approved in the US. And as we said, the National MS Society, based on their guidelines, they're saying these are thought to be safe in patients with MS. As Dr. Henson said, these were not specifically studied in patients with MS, but the general consensus and recommendation is we want patients with MS to be vaccinated to prevent COVID vaccine. Now, COVID infection. As we talked about the different medications, there are certain medications that may lower that response to the vaccine. And I think we outlined, especially the B cell therapies or the S1P1 therapies, those would significantly can affect a response to a vaccine. Otherwise, most of the other therapies are usually pretty good according to the prior studies, have responded pretty well to vaccines. Some of them, like teriflunomide, may have a reduced response, but usually adequate to protect you against an infection.
Okay, thank you, Dr. Gyang. I'd just like to add that thus far, we have not heard any safety reports in terms of other neurological reactions following these vaccines. We haven't heard anything to that effect with respect to the Moderna or Pfizer vaccines. And in the case of the AstraZeneca vaccine, I actually know some of the doctors who reviewed that case. That individual had evidence of what we call subclinical multiple sclerosis. So that individual had evidence on their MRI scan that they actually had MS that had not declared itself, probably for a number of years. And, it's not clear if the vaccine had any connection to the transverse myelitis, because this person was predisposed to develop transverse myelitis in the first place. But we haven't heard there haven't been any other red flags. The other thing I'd like to mention is that we do know that people with MS are more likely to have a relapse in the setting of a viral infection. And that probably also, even though there's not enough data to say definitively, that's likely to be the case with COVID-19. So we recommend strongly that people get vaccinated because, there's probably a greater risk of the infection itself triggering the relapse than the vaccine. So another question I'm going to direct towards Dr. Fallis. Dr. Fallis, you mentioned that non-live vaccines are generally thought to be safe or relatively safe. Can you be more precise, please?
There's no risk of disease in a non-live vaccine to the recipient. There may be, as you just mentioned, what one could call a secondary immune amplification response to the vaccination. But because the vaccines are not live, there's no possible way the person can be infected by the vaccine. And some of these non-live vaccines are not even viral particles. They're polysaccharide or sugar-coated viral components. Some of them relate to toxins that the organisms produce. So those are all very, very safe, and they've been used for many, many years. For instance, the Salk polio vaccine is a non-live polio vaccine, which came out in the 1950s.
Okay, thank you, Dr. Fallis. I now have a question I would like to address to Dr. Hansen. So Dr. Hansen, are there any recommendations for the use of other drugs during the time people with MS are vaccinated? For example, SSRI, stimulants, etc. Should we continue to take our other drugs?
Absolutely. There's no recommendation to stop anything. Even if you're on a blood thinner, you keep taking your blood thinner. The vaccine should really have no other effect on your other medications.
Okay, thank you. Another question I'm going to direct towards Dr. Gyang, and that is a lot of our audience is questioning the timing, particularly of infusions with regard to the vaccine. Now, what are the recommendations regarding that?
So timing usually comes into factor with the B cell therapies or the B cell depleting therapies because the dosing is very wide. So for instance, with ocrelizumab, it's every 6 months. And so when is the best time to get that vaccine? Now, according to the MS Society, you should wait at least 12 weeks after your last Ocrevus infusion before you get the vaccine. And, wait at least 4 weeks after completion of your COVID vaccine before you take the next Ocrevus infusion. So right in the middle, the best time is right in the middle of your dosing cycle. So anytime within that 3 to 4 month window is good. And if you take it a little bit further than that, then push that next infusion for at least 4 weeks after the second dose of the vaccine. With all the other therapies, including, Gilenya or Mayzent, the other drugs that may affect the effectiveness of the vaccine, the recommendation is just keep taking your medication and get the COVID vaccine. That's what, the guideline states. Now, if you're about to start a medication, let's say you're about to start, a medication like Gilenya, it may be better to wait and get the COVID vaccine. Wait a few weeks, about 4 weeks after you finished your COVID vaccine course before you start a medication like that. And then for people on Lemtrada or lemtuzumab, preferably don't get that vaccine within 6 months of getting your last infusion.
Okay, thank you, Dr. Gyang. Two more quick questions. The next one I'd like to direct towards Kristi. So the question is about vitamins and MS. Could you comment on recommendations regarding vitamin supplementation?
Absolutely. So as you might imagine, we get questions about this in clinic every day. And there is kind of some mixed research out there in terms of, what is good for our MS patients and what is not. I think one thing that we can all agree upon is vitamin D supplementation. There is ample research out there for vitamin D supplementation. And depending on your vitamin D levels, which your provider will check, will determine how much vitamin D you need. And vitamin D is very important in sort of down regulating inflammation in the central nervous system. So it's very important that our MS patients are taking vitamin D. Other supplementation that people consider and have been studied include things like alpha lipoic acid, biotin, turmeric, which is a sort of a natural anti-inflammatory medication. And what we would say about many of these supplements are that they are not harmful. And in some of the cases, the research jury is still out, shall we speak. I know alpha lipoic acid, for example, has been studied, significantly in peripheral nerve regeneration. And there is good research there, but the jury is still out for central nervous system repair, and that includes biotin. So what I recommend is you have a visit either with a nurse practitioner, which would be me, because I love to discuss this, or your provider, and we can go over all the supplements that you may want to take and may consider taking and decide if they would be helpful or harmful, or if, I can help you with any kind of research. But very definitely, when we're talking about supplementation, we want to make sure that every patient who is an MS patient is up to date and taking their vitamin D on a daily basis.
Thank you, Kristi. Last question for Grace Schaffner. Could you discuss the benefits of yoga in patients with MS?
Sure. Yeah, like you alluded to as well in your conversation, the symptoms that any one person with MS can vary widely. So there may be many different benefits to yoga for a patient with MS, but some of the main benefits would be helping to improve balance and flexibility. Yoga can also be a very calming, mindfulness type activity as well, which can be helpful for many of us, but especially in the population with MS, you're dealing with a lot of different things going on, potentially all at the same time. So having that time set aside to focus on movement and calming your body down, getting some flexibility in, and working on some balance can really help with that as well. But working on lengthening and stretching of your muscles, as well as working on your balance and stability and core strengthening through a lot of those different yoga poses can be really helpful in just your functional mobility, reducing pain levels, and a lot of those other mobility related symptoms that you may have associated with your MS. And I would always recommend too, potentially before you start something new, if you're a little unsure, I would talk with your neurologist about potentially a referral to a physical therapist who specializes in MS to be able to assess your specific abilities and what we may need to adapt for you to safely participate.
Thank you, Grace. And we're very fortunate here at OSU to have Grace, who is an expert in MS and physical therapy and occupational therapy in MS. And she heads a team of therapists who have special certifications to treat people in our clinic. So thank you so much. Well, I think that's all the time we have in terms of questions. We will be answering questions that you all submitted, and they'll be available. We will send you a link, and we are also recording this session so that it could be viewed at a later time by yourself, or if you want to recommend it to a friend or family member, please do. And so, Kristi, are you going to say the final words?
Absolutely. So I just want to thank all of our panelists, and I want to thank all of the attendees. And I want to let you know that if you log on to wexnermedical.osu.edu/MS community, you can learn about all the updates in our clinic, and you can view these future sessions. They will be recorded and presented at a later time. So we know there are a lot of questions out there that did not get answered or addressed, and we will answer those questions. The panelists will be assigned questions, and we will also upload those answers to our webpage if you give us just a little bit of time. And we also want to invite you to our next event, which is going to be April 8th. It's going to be the same time frame, and we really look forward to seeing you there. If you have specific questions, you can ask your providers at your visits, or you can, again, go to the website, which is wexnermedical.osu.edu/MS community. And we thank you again for joining us this evening, and thank you, panelists. Good night.